Hello, my name is Dr. Lanny Nelson, and I'm the Director of Research and Education for Protec Spine.
Hi, my name is Dr. Pranav Patel, and I'm the CEO of Protec Spine. Together, Lenny and I, we have over 40 years of spine care experience. We have prepared a number of short video clips to train you on how to use the product and what outcomes you can expect. So sit back and try to enjoy. If you have any questions, please don't hesitate to call either myself or Dr. Nelson. All right, let's start by introducing you to the device and some of the user terms that we're going to be using. Right here we have Aurora. She's going to help us demonstrate some of the moves that we're going to be doing.
Hello.
All right, so we got Aurora already set up in here. I want to start by showing you the remote control for the device, and there's only one, and there's only two buttons, up or down. So we use that to bring the chair up or down. That's what we're going to be using this for. So that's the remote, and we usually store it right there. So I'm going to go ahead and start by securing Aurora to start our treatment. The first thing we're going to do, you see this hook, it simply goes around here, and then we have the upper one, and this area, this is the lower bolster, and this is the upper bolster that we're talking about. And the second harness, the buckle, is going to go right here. And the way we suggest you do this is simply push here. Make sure there's about 2 inches of space between the cushion and the SI joint. So we got it right here, and we're going to go ahead and tighten this up by pulling like that. I'm going to have the patient, actually, let me demonstrate that again. Have you take a deep breath in, hold your breath, and there we go. And this one right here, we're going to keep it at that level. All right, so we got her situated. She's already secure. The upper torso is all set. And the first thing that I'm going to talk to you about is the loading, offloading, and uploading. The offloading is when basically when you're bringing the chair down, there's load that's being taken off from the spine. And the opposite action there is the uploading, and that's when you bring the chair up, and that's where the decompression part of the spine is coming in. All right, so we got that going. Now the next thing that we're going to talk about, another term, is what we call the sweet spot. And the sweet spot is basically the most comfortable position that the patient feels. So right now, I would just simply get it, let me know when it feels good as far as the pressure and stuff. Is that pretty good? That would be the sweet spot that we're referring to. Another thing that you're going to hear us say is the 90-90 rule, and this is where the patient is simply sitting, and you can see that the whole body. Actually, before we do that, I'm going to go ahead and introduce you to this. This is the leg sling, okay? And the way you apply that or put on is always go from the inside out, and you're going to hook it up here, and you see the way you bring it up is just simply pull this down, and wherever you like it, the desired position, you would just lock it into this position like that. And now it's not going to move. So we're going to do that for both sides here. And here we go. So we got this one, again, from the inside out, hook it up, and usually I go at the 90 degrees, and I lock it in simply by pushing it in here. Now it's nice and secure. And this position is what we refer to as the 90-90 position. Right here, you see this is a stepping stool. We want you to use this if you want to reach for something, or if you need to step on something to reach anywhere above here. Anyways, this is the 90-90 degree that we're talking about. You can see that our whole body is in 90 degree here all the way down to her leg. So that's the 90-90 position that we're talking about, or the rule. We mentioned the bottom bolster, the top bolster, and then these are the leg harness or adjusting here. So you can move this inside and out and lock it whenever that, whichever desired position that you want. That prevents it from moving. So we usually keep it right in the middle. If the patient is bigger, you may want to bring it out. So that's the locking device, and that's the lock right here. And moving up here, this is the actual the scale for the cervical. Dr. Nelson is going to be demonstrating how to use this. This thing also, this is the locking device for the cervical. You can bring it forward and back, and again, that's going to be demonstrated a little later. Here we have the shoulder ones here. This is the shoulder sling or the arm sling, and the same way, if you want to put it on, you would go inside, out, hook it up, get the desired height, and lock it in. So this is the arm sling. All right, we're going to go ahead and take that off right there. And again, we mentioned all the stuff that we need here. Now I'm going to show you some of the other tools that we're going to be using and referring to. This is what we call the gable. Again, this is going to be used for the cervical. You're going to see that in the upcoming clips. This is the S hook, and it's because of the shape of it. Again, you'll see it on the other videos coming up. All right, and here is, we use this, this is the TheraBand auxiliary seat cushion. This one right here is a padding. This is for patients that may be a little petite, or you need some room to kind of fill in the gap. So you would go ahead and put this on underneath here and tighten it up so it's, they're a little more snug in there. This one right here is what we call the anti-slip harness, and again, it goes around. We'll show that to you in the next upcoming clips, and that's what we have here. Okay. Basically, again, there's nothing mechanical except for the chair, so there's not too much problems that you're going to have as far as maintenance and stuff.
Organizing your day is critical for making your Protec spine work efficiently in your practice. I'm going to go ahead and show you how to organize the device for your daily clinical rounds. First of all, it's easy to remove the gamble, put it in its storage place. Remove the S hook, store it on the side. The shoulder slings have a hook on the side, which can also bring these cables out of the way. These go behind the neck bolster, behind the neck bolster again. And you can open up the device here. It's also important that you have your towels, your device to hold your phone and keys, your head harnesses, your sandbags, and other ancillary equipment that you're going to be using as you treat your patients during the day. Another thing we want to speak about is an anti-slip procedure. Some patients with narrower midriffs or narrower torso will need to have a device that you can place over the top of you, and as you bolster yourself in, this device will take up slack and allow for more tension between your upper and your lower bolster. A little bit later on, and for more advanced care, you'll see me talk about a thoracic anti-slip device, and I'm going to ask Aurora to step back in and just give you an introduction to this device itself. The patient will extend their arms, we'll slide this up underneath, ask her to hold on to this. At this time she'll back into the chair and sit down, and then you'll take this strap, push it over the top and down and attach it to this side, once again furthering allow her to slip up and down the chair should you need that extra security. Thank you. Protec Spine wants you to know that there are very few contraindications for using our device. However, we embrace the same contraindications that are standard for manipulative therapy. We found there are 4 signs that are critical for how you triage your patient on our device. I would like to demonstrate those 4 signs for you. I'm going to ask Aurora to come back in again. Those 4 signs are hip flexion sign, seated straight leg raise sign, Shimizu reflex or Shimizu sign, and the pectoralis reflex. So on the first sign, hip flexion sign, I'd ask the patient to put their legs as far apart as their shoulder. They'll activate their core and then just roll forward, rocking on their hip sockets, not using their low back for flexion. So I'm going to have Aurora go ahead and demonstrate the proper way to do this. This is a negative test. So Aurora, just head bend over. You can see that she gets below 60 degrees. You can see that her back doesn't bend, and she does a very clinical good sign. Go back up. Now I'm going to ask Aurora this time to show you what a positive sign looks like. Once again, the legs are the shoulder width apart. When she bends forward, you will see her spine immediately bend. Now, this indicates that the hamstrings are too tight in this region called the lower extremity region that facilitates her inability to flex in the lumbar spine. Dr. Patel will talk about that a little later on and demonstrate how to treat an IT band SI joint syndrome. But for right now, what that should tell you is if the hamstrings are driving the back pain, then when you put your patient in Protec, you want to make sure maybe you're 60% hamstring, 40% lumbar. If the lumbar and this hip flexion test is negative, then we know we're probably more mechanical up here and less on the hamstring. The next sign we want to talk about is called the seated straight leg raise sign. So I'm going to ask Aurora to sit down on this position. I put her in a 90-90 position that Dr. Patel talked about earlier. Have her hold her hands here, and on this position, when she's seated, I'm going to bring her leg out and watch if she backward bends. Now that would be a grade 1 response. A negative response, but she would maintain that position, and when I bring her leg out, she doesn't backward bend at all. A grade 2 means she goes back about 30 degrees and then back up to normal. So let's go through this again. Give me a negative test where you don't bend backwards. She's negative, she just stays in this position. A grade 1 test, I bring it up, she bends back, she goes back about 15 to 20 degrees, back up. A grade 2, out, she goes back a little bit more, and that'll help us later on when we talk about how you have to prescribe care and triage your care. If we have a grade 3 response, and her hands break, and she goes down and she grimaces, we found that that case is necessary for you to look at advanced imaging. If you have a positive seated straight leg raise where the hands break and they go to a tripod position, that's very critical that you look at advanced imaging studies or you get an MRI to look at the compression on the nervets. The next test is called Shimizu reflex or the scapular humeral reflex. I'm going to spin you around here. On this test, the hands are loosely to the ground. The Japanese looked at this study when they're looking at a reflex between the occipits C1 and C2. We know this is the blind spot in the spine. Therefore, the Japanese were able to find this. The sign is given by taking and karate chopping on top of the shoulder. A negative sign is that the shoulders stay down. A positive sign is if the shoulder goes up in the air quite violently. Negative sign, down. Positive sign, down, and she Raliki comes up. If you get a positive Shimizu sign, once again, that calls for advanced imaging on the cervical spine before you put them on the Protec device. The last sign is called the pectoralis reflex. The pectoralis reflex also corresponds to the Shimizu or scapular humeral reflex. You do that by having her contract her pec on the front side, and then when she relaxes it, I just tap it. And the negative sign is the shoulder stays flat. Make it tight again, and I tap it. And a positive test would be when the shoulder, let's demonstrate a positive test again, Aurora, get it, and the shoulder goes forward aggressively. If the shoulder goes forward when you do your pectoralis reflex, once again, that's an indication that we need to do some advanced imaging.
All right, I'm going to go ahead and demonstrate the lumbar treatment with the help of Aurora here. I already have set her up with the leg slings. They're all properly secure, and what we want to do is get the proper height here. So you want to do the 2-finger distance from her ASIS and the cushion, the lower bolster right there. So now we're set. Now we're going to try to get her to that comfort level where the sweet spot is we refer to as. So I'm going to go ahead and ask Aurora, tell me where it feels better, here or here?
Here.
Okay, so we'll leave that one. Same thing here. I'm going to bring it down. Tell me when you start feeling a little better. Is that better or is that better?
That's good.
This one right here. Okay, let's leave it right there. We got that secure, and then also, Aurora, tell me where does it feel better, more comfortable? Is that okay right there?
Yes.
Okay, I'm going to go ahead and lock that up. So now we're all set to go. And here's what we're going to do. We're going to go ahead and have Aurora take a deep breath in and hold her breath, and we're going to keep it right there. And then here, the upper bolster doesn't need to be as tight as the lower one because it's going to make a funnel shape. But do keep in mind, you know, if you have a patient, the breast tissue and stuff, that you don't want to put the patient in a compromised position. So what we recommend is either, you know, use a towel or something to drape over, or also like a gown, whatever it takes, just so we want to make sure the decency is all there and the patient's not feeling uncomfortable or compromised. So now we have her here. She's in that 90-degree, 90-90 rule that we're talking about here, and I'm going to get started. The simple rule that I follow, there's 6 moves. We do the right, left, up, down, right, left, in, out, and rotation. Okay, let me do that again. It's going to be up, down, left, right, in, out, and rotation. If you keep that simple, you'll be able to treat about 90% of the patients in the lumbar conditions. Okay, so here we go. We have her all set up, and what I'm going to do, and what I normally do is I have the patient in this position and I give them the remote and I ask them to go ahead, Aurora, I want you to bring the chair down until you feel a little offloading, or you're gonna feel your lower back muscles actually opening up there. I want you to keep it there. When you find that spot, keep it there for about 10, 15 seconds, and then after that, I want you to go ahead and bring it back up to neutral, which is a position we started, and then I want you to go ahead and bring it down again, and maybe a little lower than last time, hold it for 10, 15 seconds, bring it back up. What we're doing here is we're pumping the spine, or I like to even tell the patient warming up the back before we get started. So what I do in my office is I have everybody set this up for me, my staff sets that up, I come in there, the patient's already getting some activity or therapy already done. So just imagine we come back here, it's been about anywhere 5-7 minutes, whatever you choose to do, and then we're ready to get started. So look, Aurora, what I'd like you to do is go ahead and bring the chair to the point where it's barely touching your bottom, okay? And let me know if you're ready. And what I normally suggest is just get this out of the way because you won't need the stepping stool for a while, and we get started. So the way I go is, first of all, we already did the up and down by Aurora actually doing that by herself, or you could do it to aid her the first few times. And so now we got the up and down, now we're gonna go left and right. And here's how I usually do that. I come in here, and again, none of these moves here, the patient should be, or the practitioner should be exerting too much pressure. It should be nice and easy. So when we do that here, we push there. Is that comfortable for you? Okay, and then what I do is I come on this side and do the same thing. Let me know if that's comfortable for you. So here I'm trying to achieve the left and right motion. And after we do that a couple of times, and along with her prepping to get the spine open and closed, we are ready to start the other move. Is that okay? Mm-hmm. Okay. And now the next thing that I do is I grab the leg here, I bring the leg sling up like that. I do it on right there, and this is comfortable. Is this okay for you?
Yes.
Okay, so go ahead and relax this, and I'm gonna raise this. Tell me when you start feeling the tension on your leg.
Right now.
Okay, so this is about the point that I like to get started. Here, she's already has some tension. What I do is I come in right here. The reason is I don't want her right leg to actually aid in that, so I want to focus all on her left leg. So we're gonna go in here and tell me when that tension is. You feel that tension? So I usually go ahead and get to that point, and then I give it a quick 3 pushes on there, and then we get the motion. Another thing that I always do is I bring that up. Does that feel okay? Is that a little more tension there? Okay, I'm gonna go a little bit more. Tell me when it becomes too much here. Feel that? Okay, is that too much? Let's go one more. And how about that? Is that too much? Okay, so now we know that's her max, and that's what we want to try to improve. So I bring it down a little bit, and then I externally rotate her leg and do the same thing here, and I try to do it in different degrees. So I go a little lower, a little higher, we get that going, and then internally rotate as well. And the patient will feel the pressure on different parts of the leg when you do internally rotation. Did you feel that? Did you feel it different when we internally rotate? Good. All right, so we're gonna go ahead and do that, and then I usually bring them back to this position, and if you have a runner or anybody, or you wanna work on the muscles behind the leg, by doing this, you feel that pressure there? Okay, and the patient will actually feel that right away. Another thing, you can also internally and externally rotate the foot, and that's also gonna get to the other muscles that you wanna work on. So here's one thing that I do, that I'm gonna go ahead, and I'm gonna let this leg rest, and I'm gonna do the same things on the opposite side. Again, I'll do it really briefly. I'm gonna go into this motion, bring it up and down to the proper height, and then internally, externally rotate, bring it back down, and then you're gonna do this motion, okay? So what we just demonstrated is the up, down, left, right. Now I'm gonna show you the in and out, okay? And here's how I do this. I have the patient, I kind of get them right here, and I use my leg to help me support it. Again, I'm not exerting any pressure here. I'm gonna have you bring the table down, and I'm gonna push posteriorly, as you see here. Now, Aurora, I want you to bring it up until I tell you to stop. And this is where the compression or uploading is happening here. Just keep going until I tell you to stop. Good. Bring it back down. And don't stop until I tell you. And then when you get a little more slack, I want you to push a little further back, and I'll bring it back up again. Bring it all the way up until I tell you to stop. I do this about 3 times. And you see her hip is going posteriorly every time we do that. And after that, I'll say, okay, go ahead and Aurora, bring the chair all the way down. And this is that rotation, that the final phase that we're talking about here. Go ahead and keep bringing it down. And you'll see the hip rotation here. And again, if you do it properly, you got your feet in the proper position, you're not going to exert any pressure. So here we go. We got that rotation, and then I usually do it in both direction here. and then about 2 or 3 times. Then I push posteriorly and I have the patient bring the chair back up again and try to get him back to the neutral position. Okay, there you go, good. And that's it. And then we would go ahead and get the patient off. The way I suggest you get the patient off, release the legs first and take this off. Oh, there we go.
Have a nice day.
Go up here. So we get that. And we're gonna do the same thing on this side. Okay. And when you release that, I suggest you hold on to this belt because there's a lot of tension and pressure in here, and squeeze and slowly pull that out and take that off. And now if this patient is in a lot of pain, one of the things I suggest as far as bringing the patient up is Aurora, go ahead and grab this rope, and I want you to go ahead and step on that foot, and I'm going to bring you up slowly and bring that chair up and help aid the patient in getting up. All right, here, go, come on up, and there you are. I'm going to go ahead and start by doing what we call the contract, relax, antagonist, and contract again. And the way I'm going to do that, I'm going to have the patient get in this position, traction it out, and this is what we call the 5-to-1 ratio, 5 quads to 1 hamstring. And the way I do it is I tell the patient, when I go like this, I want you to contract or make that muscle tight, okay? And then hold it, and this is to release. And we're going to do 5 of those with one of the hamstring. I'm going to demonstrate that. So I want you to go ahead and make this muscle tight, hold, hold, release. Again, hold, hold, release. Hold, hold, and release. Again, hold, hold, and release. You do that about 5 times to one of these where this is the hamstring. Go ahead and try to push down. Hold for 2 seconds, 1, 2, and release. All right? And then we're going to do the same thing on this side. You can do them together or actually do one leg at a time. And what I'll do is I'll go ahead and reach over and I'll get the device that I like to use in my office here. And we're going to go ahead and get her into the position. Tell me when you start feeling the traction. Okay, is that tension right there?
Yeah.
Okay, so then what I do is I go ahead and take this one right here. And while it's in tension mode, go ahead and apply pressure in this area all the way. Okay, and do that for a little bit. And then you can have the patient, we're going to go on this side and do the opposite side as well. Just like that. Okay, and then I'm going to have the patient hold it. All right. And then what we recommend is doing the 0, 30, 60 rule. So now get her to about 30 degrees and repeat the same thing again. I want you to go ahead and contract and 1, 2, release, contract, 1, 2, release. Again, you do 5 of those and then have the patient push down, 1, 2, and release. You could do the same thing and now do the same exact motion that we did before. We're going to go ahead and get this in here and do this at 30 degrees. Same thing, bring them on this side and get them in that tension phase right here and do that for about 30 seconds as well. Okay? We recommend, hold this for me please. We recommend that, again, you could do the same testing again, bring it to 60 degrees. And this will actually help hold the patient's adjustment and it's highly effective for all the low back conditions that we treat in our office. All right, I want to show the SI joint treatment here as well. I'm going to go ahead and have Aurora hold the remote. And Aurora, I want you to bring it down, bring the chair down where it's barely touching your butt, okay? Or your body. Okay, now I'm going to go ahead and get her foot right between my knee here, and I'm going to pull forward right here. I usually do about 3 or 4 and push posteriorly as well, anteriorly, posteriorly, and you can see from the side the movement there. And then I get into about a 30-degree angle and do the same thing. We'll do it on both sides if needed. And same thing, pull forward, back, 30 degrees, back, and forward.
One of the most difficult things to treat in acute spine care clinic is the acute onset of low back pain. This is that patient that can't get out of the car, that calls you on Christmas Eve and says, I can't get off the floor. We feel that Protec Spine is the most valid way to handle that acute spinal injury. We feel this is one of the hallmarks of why this apparatus is so important to the clinical practitioner. So in this next demonstration, I'm going to show you the efficacy of why this is so important in a spine care clinic. So I'm going to assimilate that this person had a positive, see the straight leg raise sign, which was almost at about a grade 2 backward bending, and maybe almost to the point of let go, and he's probably have a grade 2 redic. So the best thing to do is I'm going to get him out of his car, he'll have a back belt on, and he'll be on crutches. So when that person will approach the machine, he'll come in and he'll be in a very difficult place to move, and he'll have a back pain on, or he's a post-surgical patient that's following up for care and he's had some post-surgical back pain. At this position, I'll have him take another step forward. I'm going to have him turn his back to the machine, and then I'm going to have him, or if you'll hold this out from the side, I'll have him position him belt back. I'm going to lower the seat to the lowest possible position that I can, and then I'm going to go ahead and take his arm and have him grab onto this rope up high, and then take this crutch away from him, and take this arm and grab this and take this crutch away. Once I've got him in this position, he can put downward pressures on the upper bolster with his elbow, and at that time I don't want him to sit down, I just want him to hold him in this position. And then I'm going to remove his back belt. And now I have a couple of options. In an acute back pain patient, any uploading might be uncomfortable. So sometimes it's valued if I can use a device that's going to give him some flexibility when I load his spine. I can put this on the chair, and now what I'm going to do is bring the chair up to him, and as he feels it, I'm going to have him set back lightly, and then he'll slide back in this position. It's pretty critical now to get the leg harnesses on as quick as I can to offload his lumbar spine. So we'll go here, and as Dr. Patel indicated before, we want to always strive to get him to that sweet spot position. Once again, we use the exact same terminology that you were taught in the previous video. We're going to go up, downs, right, lefts, in, outs, and then rotate. Now, the funny thing about an acute back pain patient is these necessarily do not have to be symmetrical. So we want you to continue to ask the patient, better higher or better lower. He will immediately feel better when you put him in the harness and you secure his back. So as soon as I put him in here, it's going to simulate. Take a deep breath. We want to do this in 2 progressions, 1001, 1002. Take another deep breath. And blow it out on me. Easy. So you want to do it in 2 sets. Once we put him on, he'll start to feel better. We want to readjust to comfort. Comfortable here or lower?
Lower.
Lower
That's
there.
right, yeah.
And lower here again as well.
Yeah.
Once we get him in a position of comfort, then we want to start him to offload to find that sweet spot. I'll give the control back to the patient, have him offload a couple of pounds, 1001, 1002, take a deep breath, blow it out, and I'm going to cinch the lower harness, and once again, cinch the top harness. Now, as Dr. Patel indicated before, sometimes it's better to hold on to this and let this go, because I had a small twist in that fiber, and I don't want to. I want to make sure I get that out of there. One more time, take a deep breath and push in. Now, in this position, I'm ready to begin the treatment. In an acute back pain patient, we don't know if free fall works the best. In fact, studies say it's probably not best because we have so much reactive splinting. So let that patient find that sweet spot. So go ahead and take yourself down till you feel comfortable and your back pain has abated. Once the back pain is abated, we'll stop there. And now once again, we want him to go up. So let's go back up, 1001, 1000, stop. Back down, sweet spot. Back up, a little bit of pain, stop. Back down, sweet spot. Back up, pain, stop. Back down, sweet spot. Hold. Now, once he finds a sweet spot after 3 or 4 cycles of that, let him sit there for a couple of seconds. Let him calm down. Let him relax. Give the tissue time to elongate and give the tissue time to get that new norm. Once again, back up. Pain, ouch. Back down, sweet spot. Are you comfortable here? try to adjust the legs. Every time we adjust the leg up and down, when we have him in a flex position, we begin to traction the nerve root. And another great technique on this as well is you can put pressure on the front side of the disc space here. You can lean in and now have him go up to pain and sweet spot. And back up, pain, stop, and sweet spot. You can put pressure backwards for extension if they happen to be more extension biased rather than flexion biased. You can also do the same with a little bit of forward flexion. This is very comforting. In this position, you notice how both of my hands are going to come around this apparatus. I'm going to pull, lean back, and he'll go up to pain and off to sweet spot. So, once again, let's review. Up, down, right, left, in, out, and rotation. You can also apply the same technique if you want to pick the side. Let's say he had a right radic. I can pull, rotate to the side of pain, go up to pain, stop, down the sweet spot. And he can melt this in the same position. And every time I could pull him a little bit more, I could succumb that disc to the levers that are going to change the annular fibers to twist and distract at the same time. It's also critical to notice that I don't have him in a free fall state. I have him a little bit of pressure underneath his bottom. So we'll do that for 4 or 5 times. A lot of times we'll do this procedure. We put him on crutches. We want him to walk on the crutches for 5 or 6 minutes. It's really critical in acute low back pain that once you treat them, you get them moving in active care. So we like to recommend put them on the crutches, walk them down the hallway for 3 or 4 minutes, maybe bring them back in, and repeat this sequence. We found it most effective to do maybe 3 cycles in an acute back pain patient. Now, I know this is complicated on Christmas Eve, but hopefully he will buy you an extra pound of chocolates. It's better to do the cyclic. It's better to go easy. Less is better than more in this position. Notice I don't have him in free fall. You are always adjusting for the sweet spot. That is critical. Now I'm going to ask Aurora to step back in. I'm going to get this patient out of here. So first thing we're going to do is we know he's got him with a little bit of comfort. Are you comfortable here? I'm going to have him lower a little bit more, stop, and then I'm going to go ahead and let this leg come down. Now, when I put him in this position, I want to be comfortable. If I drop that leg quick, I'm going to throw his spine into extension. So I'm going to remove this, keep it to the side, have this here, drop his leg again, down to the side. Okay, now what I'm going to do is have him reach up, hold here, have the patient hold there. Take a deep breath and hold it. I'm going to do as Dr. Patel suggested, hold on to this and extend this so it doesn't unload abruptly. Hold here. And Aurora, if you would, use the up button for me. She's going to raise the chair. He's going to pull at the same time. When he gets to a standing position, I'll take the back belt, hold there. I will replace the back belt in this position. One crutch, the arm comes let go. The arm crutch, now. The other crutch here. And now the patient can step away from the machine and I can begin the active care phase of his decompression event. Let's review. Up, down, one plane. Up, down, right and left plane. Up, down, rotation plane if I need to, but you want to use small increments. The importance of the cushion is it allows you to upload and offload easy. One of the most difficult things to treat is cervical brachial pathology. We at Protec Spine feel this is the hallmark of our machine. In fact, if any other thing when you boil it down to, I personally believe this is the greatest asset that this provides to any spinal care facility. Now I'm going to demonstrate 2 concepts here, but before I do, I want to give you a little bit of mechanistic background behind why this is so effective. I kind of stumbled onto this by working with professional and Division I football players. So I hope to allude to that. Don't let me forget that too soon. But before I forget, I want to talk about the setup. I've asked Aurora to sit in the chair, and I'm going to go ahead and set her legs to begin with, like we've showed you in the past before. I'm just going to bring the legs here and here. And then I'm going to raise the chair to its highest possible position. And as she comes up higher, I'm going to readjust the legs so that I can get her in this position. The reason I'm going to raise her as high as possible position because I'm going to use the cervical harness to begin with, and I have to make a determination. First of all, do I just put the gamble in by itself? If you have a larger person, or say a defensive tackle that has a huge, enormous melon, I might have to use the larger leather-strapped harness. And I can accommodate that by using a large harness because the gamble and the chair height gives me that play so that I can adjust it. In smaller athletes or smaller females, I have to go to a more or less form-fitting cotton harness, which is going to require that it's going to put too much tension on her head, so I have to use an S-hook in that and able to get the distance. So you want to take the chair as high as you can, and then you want to go ahead and get the right appendage. So I'm going to change out the gamble and show you how I have to fit her for this harness. Another thing I want to mention really quickly is these are easy to purchase, and by contacting Protec Spine, we're able to provide these for you. They're very inexpensive. I like to order these per patient so that each patient has their own. If you don't have that option, you can be sure and put some either Taline or face paper underneath this. But in most patients, and females in particular, they're going to want to have their own harness. So in this position, I'm going to remove the gable. I'm going to apply the S-hook, and then I'm going to apply the gable to the S-hook. And you see that just provided about another 4 inches so that I can accommodate that harness. When you put the harness on, I want you to, sometimes this is a little awkward, so it takes a little practice to be good at this. I would recommend that you always put the Velcro straps in the back and that you fixate one side to start with. So we're going to start here, and then we're going to come around here, and then we always want to go from back to front. So I'm going to go from the back to the front and position the other harness on the other side. From that position, I want to pull a strap forward here and a forward position on this position. Pull the other strap here. Let me get out from underneath her ponytail and go forward in this position. Now you can see that there's a digital scale up here. The digital scale has to be tailored when you add the S-hook, because anytime I start to offload the spine by dropping the chair down, you're going to see that I'm putting pressure on the scale. So it's important to zero out the scale before you do any treatment. Now, this is the fun stuff. I've pre-examined Aurora and found out that she had no negative reflexes. Her Shimizu was negative, pec reflex was negative, and I palpated that she had some dysfunction in the cervical spine at approximately C3, C4. So I'm going to ask her to objectify that to you when I begin treatment on her. So what I'm going to do now is I'm going to drop her down, and if you look on the scale, right now I'm at 3 pounds of pressure on her neck. This is what makes Protec Spine so valuable, and this is what gives us a hallmark niche in the market. Because at 3 pounds of offload, I can take her neck and I can palpate it, and I want to use a technique that we're going to introduce called glide, pivot, and rotate. So I'm going to put my left hand here, her right hand back here, and I'm going to push, and I'm going to glide, and I'm going to rotate her spine. Now there is so little pressure on her neck, and this is what's critical about this. When we lay a patient flat on their back and we pull on their neck, a lot of times they will reactively splint. We will put the levator and the trapezius into spasm, and they will try to guard that movement. When I drop the seat down, for some reason I don't have that same reactive splinting. Over-the-door traction units with water do the same thing. Now I don't know if I've got it in neutral buoyancy because of the legs. We hope to study that when Protec is in a few more university settings. But when I put her legs in this position and I have her recline backwards, I can use very limited poundage because as I drop her down, I don't have that same inhibition. A lot of times when I do cervical spine, especially to manipulate the cervical spine during this treatment, I like to remove the back cushion. It's easy to remove, and when I can remove that, that allows me to add more vibration therapy to the shoulders, or I can use laser, ultrasound, or other modalities as I need to treat the spine. So let's say this isn't really Aurora, but let's say this is a defensive tackle at one of my major universities. He's 6'6", 265, 300 pounds, and he has no neck, and there's so much reactive splitting in here that I can't do it. Let me repeat the procedure. Hand here and here, and once again, I can find the sweet spot, and normally we recommend in Protec Spine that you want to be anywhere from 3 to 5 pounds. There, that's 6 pounds, which is hardly anything. Aurora, can you feel that on your neck?
Mm-hmm.
Is that uncomfortable at all?
No.
So when I take your hand here and I press here, we want to pivot and glide. And in this position, you can stair step and you can milk every one of her facets. And she can tell that facet on this side, which is really sore. Can you confirm that?
Yeah.
Give me a number from 0 to 10 on that soreness.
6.
About a 6. So when I push in, I'm going to push, glide, and then rotate that spine. And I'll go to the other side and actually adjust that for in a minute. But let's go back to that big full alignment that I'm just talking about. So let's say now let's repaint that picture. She's 6'5", she weighs close to 300 pounds, and she has massive trapezius and levator scapula. At the University of Missouri, when we were doing some work with them, we found out that I could take the arm slings, bring this in this position about over the top of her shoulder, and I could sling this arm. I've got no pressure on her neck, and then just have them lightly grab this anywhere they feel comfortable. Sometimes it's better that, and then just rest her arm on that sling. I can do the same on the opposite arm. Bring this up to this position, reach back, and make it comfortable and drop her arm in there. Are you comfortable there?
Yes.
Once again, we have no load on her neck. I found out something pretty interesting. I can adjust this locking device either forward or back to give me more on the lower spine or up high more straight on the upper cervical spine. But now I take her and I drop her down and I try to get that same, that's 1.1, there's 1.3, there's 2.6 pounds of pressure, there's 3.5 pounds of pressure. At this position, when I've slinged this arm, I've taken all the reactive splitting out of the neck and out of the trapezius. So now what I can do in that big football athlete is I can once again mobilize and distract the neck, and I can do so with so little effort because I've taken away all the inhibition on the shoulder. Now I'm going ahead and I'm going to use my hand, press against them, and my left finger here is going to be on that segmental dysfunction as we mentioned before. I'm going to press, rotate, and just open up that joint space, and you can feel it open up there.
Yeah.
Feel that? You feel that just click?
Yes.
That just adjusted her neck, and I did that with 2.8 pounds of pressure offload, but I had to sling her arms in order to get that. With Protec Spine, we feel this is the biggest advancement in managing cervical brachial pathology because it's the only device on the market where we can offload this whole complex and still treat segmental dysfunction. Now, why is this so important? If we think about it, it makes logical sense. If this is innervated by C5, C6, C4, doesn't it make sense to offload it before I treat it? Think about that. Anytime I have an athlete who injures their shoulder or their upper extremity, 9 times out of 10, there's going to be a proportion that can be associated to the cervical spine. By offloading the cervical spine and then treating this, you take the interference here to allow you to treat the lower extremity. I mean the upper extremity. I'm not going to spend any time talking about that, but those are some future advances that you can become aware of once you're a member of the Protec Spine family. I'm going to go ahead and take her out of this now. I've got no pressure on her face at all, so I'm going to drop this one down here. Come over here, take it off. I'm going to hook behind the back like we talked about before. Hook those up. Take the gable off. and here. Remove it from front to back. I'll take a magic marker and write the patient's name on the side of this so that they can understand that that's personalized for them. And then drop the legs. At the same time, I'm going to drop her chair. And go ahead and fetal touch. And go ahead and stand. Now, one thing we like to do when we're done with this is do some elements of physical exercise, and I'm going to be demonstrating that next. Now that we've had a chance to see some cervical brachial decompression, I like to call that the hangman reflex. Clinical data will be coming, but for now we'll just call that inhibition when we drop the neck and we sling the arms. Now I'd like to show you some active care following cervical distraction. And this is kind of a neat concept. I'm going to ask Aria to go ahead and Aurora to drop that down as far as she can till she feels she's comfortable. Go ahead and drop it till you feel a pretty good tug on your neck. Notice how she's at 15.2 pounds right now. Go back up to neutral. And she feels comfortable at that. Now let's not forget that I adjusted her neck at about 3.5 pounds because I inhibited that reflex. But she feels comfortable at about 14 to 15 pounds. Her neck weighs approximately 8 to 12 pounds, so in that position, she's going to feel better if she can offload that. Now, I'd like her to find that sweet spot again. I don't have them do that a couple of times, so let's go back down. You feel comfortable to where you feel a good tug. That's good, because she's about 12 pounds, and I'm okay with 12 pounds. Protec Spine does not want you to exceed any more than 18. That's at the high end of what we'd expect because that's more than the weight of the head. So we'd like you to keep it anywhere from 12 to 15 pounds. And then I'm going to give her this command. Let's go back up to neutral. Okay, and now we're going to go down. And this time as you go down, I want you to follow me and turn your head to the right. So go down to your sweet spot, turn your head, turn, 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 turn. Now push back lightly against my hand and bring it back up and go to neutral. Come back up again. Now you're back to neutral. Let's have you go back down to your sweet spot again. Look towards me. Turn your head here as far as you can. Turn, 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 turn. And then when I get to that extreme, sometimes I'll just bounce that. 1, 2, 3, 4. Come back up to neutral. Go straight ahead. And go to the left side again. Once you're neutral, down. Come towards me. This is the same technique that Dr. Patel talked about earlier. We like to bounce this. This is a swing and bounce technique that he showed you on the IT band. Once I get it under load, I want to take it and just bounce it lightly, go to neutral, come back up to 0. At that same time, you could apply vibration if you'd like to in the posterior of that. I'll have the patient do that anywhere from 3 to 5 minutes, go back up to neutral position, do some active care. If you find more restriction in an athlete, you might want them to pull your hands back and forth.
All right, thank you for watching. This concludes our basic Protec Spine training video, which we like to call 101 because it's basically all the main things that you need to know. It may seem like a lot, but when you start doing these treatments, in my office, the average time a patient's on this device is anywhere from 8 to 10 minutes, which majority of it can be achieved by your associates or any of the people working in your office. This will take care of about 90% of the patients that you see or the conditions that you see or treat in your clinic. And after you become a part of the Protec family, we will share more advanced protocols and different ways to handle different situations.
By no way does this video try to show you the thousands of possibilities that we can achieve by using the Protec Spine. We haven't shown you hip flexion, treatments for frozen shoulder. There's a whole scoliotic protocol we're working on. Hip impairments, dysfunction associated with post-surgical spine fusion, post-lumbar spine fusion, thoracic disc discompression. So there's a lot of things that we can do. And we know these first initial videos, we just like you to become accustomed to it so you can have more of a hands-on position. After you purchase Protec Spine, we'll do everything we can to support you. If you want us to bring it to your clinic or to your facility and do a personal training demonstration, please contact our office and we'll be happy to engage you at any possible we can. you can please call our office individually, or if you have any questions, you can go see us at www.protecspine.net. Once again, we'd like to thank you. We'd like to thank Aurora for her participation with us today, and we look forward to meeting you in the future. Thank you.
Thank you for watching.